Welcome to Las Vegas. Let's talk about blue jeans. Think about your favorite pair. I actually brought mine with me. These are the ones that I wore on the plane on the way here. They are my favorite jeans. So think about your favorite jeans. Why do we like them? Is it the fit? Is it the color? Is it the fact that there's something about them that just makes us feel comfortable? For me, that's probably one of the most important things about these. I also like the fact that they're a little bit dressy, they're a little bit casual. But let's shift now. Let's think about blue jeans for our patients. And really what we're talking about is how to make the medication fit better. How to tailor treatment for a particular patient, to individualize what we're doing, moving beyond one size fits all. I imagine my favorite blue jeans would not fit some of you. They may fit some of you perfectly, but there's a reason that we don't have one size fits all blue jeans. But let's talk about why we're here today. We're going to talk about really how to interpret a pharmacogenetic test result. And here we're going to get into a lot of the nitty-gritty, and it's going to be fun. We're going to talk about how we look beyond a pharmacogenetic test result, how we think about the environmental factors, about the concomitant medications, about the other clinical factors that are going to drive patients' response. We're going to talk about how we can actually implement, in other words, when to and when not to implement pharmacogenetic testing. And perhaps most importantly, we're going to talk about how to communicate these results, both to other clinicians as well as to our patients and their families. When we're talking about pharmacogenetics, we really can think about this as two sides of a coin. And I know that this is probably review for most of you in the audience and at home. But when we're thinking about this coin, on one side we have the pharmacokinetic factors. So in other words, that variation in genes that will produce enzymes that have varying levels of activity that then gives rise to difference in metabolism, differences in clearance of medication, and as a result of that, we have differences in blood levels. We have some folks with much faster metabolism of the medication who have lower blood levels. We have some folks with lower metabolism who have higher blood levels. And we're going to talk about that in a couple of different ways. But let's briefly flip the coin and look at the other side. And that's really what I call target engagement. So where the rubber meets the road. This is variation in the target for our medications. Now with the SSRIs, we're often thinking about that in terms of the serotonin transporter, which we block, of course. But we can also think about it in terms of the 5-HT2A receptor. We can think about it in terms of a number of other receptors. So when we think about medication and we think about response, we often delude ourselves, I think, into believing that there's a direct relationship between the medication and the response. So in the office, how well is the medication working? Do you feel like the medication is giving any side effects? Are there any aspects of the medication that you're not liking? As if there's a direct relationship between the medication and the clinical outcome. The reality is we all know from seeing these patients that there are a number of intervening factors. We know that medication response is driven by age. We know that medication response is driven by adherence. I don't know about you, most of my patients don't take their medication entirely as prescribed. But we also know that there's variation in these pharmacokinetic genes that I alluded to. And we're going to focus on those two, 2C19 and 2D6, because those are the ones where we really have the most evidence. Beyond that, we know that age influences metabolism. We know that medication dose is related to medication level, and we know that medication level for some medications can actually influence its own metabolism. We know that adherence affects medication level, and then we know that exposure, concentration over time is what I mean when I'm saying exposure, is going to produce differences in terms of target engagement, again, where the rubber's meeting the road. We know that time is also important. And last, we know that there are a surfeit of clinical factors, which we all know as we're seeing that patient in the office. This is a patient who might not do well with this particular treatment versus that particular treatment, based on a comorbidity pattern, based on the target disorder, based on some other comorbidity or early life adversity, as you heard Dr. McIntyre talk about. And the coalescence of those factors is ultimately what drives our response. So what's the take-home message here? Number one, it is not just environment. Number two, it is not just comorbidity. Number three, it is not just adherence. Number four, it is not just pharmacogenetics. Now, I love this question. It's meant to be a little provocative. Is there a relationship between blood level and response to psychotropic medications? We have to be a little bit indirect as we think about this question. But in terms of what we know, largely from meta-analyses, we know that SSRIs in anxiety disorders, in adults and in pediatric populations, dose is related to response. Weakly so in pediatric populations, but definitely in adults. For OCD, we've known for more than a decade that response is related to our dose of our SSRI. In MDD, a beautiful meta-analysis now published almost a decade ago in the Green Journal, the American Journal of Psychiatry, shows us that there is a dose-related increase in response. As we increase the dose of SSRIs, we get a greater magnitude of response, and we also tend to get faster response. Although there's no free lunch, as we know, and we pay for that in terms of side effects. And last, we know that there are dose-response relationships for benzodiazepines, although those are a bit more complicated. All right. Now, in terms of this variation in blood level with these medications, we know that most of that variation is probably related to variation in our CYP450 enzymes, the CYPs. So let's take a moment and just remember how many of our medications are metabolized via these systems. Well, between 3A4 and 2D6, we're actually talking about half of psychotropic medications. We include 2C19 and 1A2, we're now talking about 2/3 of psychotropic medications that we use. And then we have, to a lesser extent, really just with 2 antidepressant medications, the effect of 2B6, 2C9, and finally about 15 through other pathways. All right, here's where we have to spend a couple of slides really getting into the nitty-gritty. So I do apologize in advance for that, but just bear with me for a moment. There is a nomenclature for pharmacogenetic testing results. And it's actually pretty straightforward. We know that we have genetic variants. We know that those produce differences, ultimately in terms of the enzyme that's produced. We also have these things called star alleles. So when you get the results of a pharmacogenetic testing report, you see the intermediate, poor, rapid metabolizer, those phenotypes. But what you also see is a star 1/star 1 or star 1/star 41 or star 4/4. Essentially what that refers to is the 2 forms of the gene. So we always have 2, generally, one from mom, one from dad. And those 2 alleles combined give us the phenotype. In other words, that poor metabolizer, intermediate metabolizer, rapid metabolizer. We're going to go through this in a little bit more detail. All right. So with regard to star 1, when you see that represented, that generally is the quote-unquote normal form. So the wild type, if you will. The normal metabolizer, oftentimes if we have star 1 and star 1. But we can have more than one variant. So let's look at this visually, and I tend to be a very, very visual learner. So when we think about DNA, we know that that is transcribed to produce messenger RNA. That messenger RNA is translated to produce our protein, in this case, CYP2D6. So in the case of that star 1, the normal form, we have a normal 2D6 gene that gives us normal messenger RNA for 2D6, and that gives us a normal 2D6 protein. But here's where the variation comes in. We can have one particular allele that's associated with reduced function. So in this case, we have a mutation in that 2D6 gene that gives us a mutation in the 2D6 messenger RNA, and that gives us a defect in our 2D6 protein. We can also have something that I have, which is a deletion in my 2D6 gene. It explains a lot. So in my case, I have a subsequent deletion in my messenger RNA for 2D6. And guess what? I have no 2D6. So we can also have a scenario that makes me really envious as a poor metabolizer of 2D6, in which we have duplication. So I have two forms of that 2D6 gene. Guess what? I have double the 2D6 messenger RNA, and I have double the 2D6 protein. So I'm going to be a faster 2D6 metabolizer. Let's look at it another way. This is the pharmacogenetic speedometer. So on one end, we have the poor metabolizer, two no function alleles. On the other end, we have the increased function alleles, two of them typically, but we can also have duplication. And that patient is going to be an ultra-rapid metabolizer. I'm sticking with the visual stuff because that's how I learn. I can think about this as a bathtub, and I think sometimes that's helpful when I'm talking with my residents, so feel free to use this with trainees. When we think about how our guidelines tell us to use antidepressant medications, it's often starting at a standard dose, a standard titration. That's equivalent to turning on the bathtub at the same rate in all of our patients. We can think about the clearance of the medication, the metabolism of the medication, as the size of the bathtub drain. So in other words, when we turn on the water at the same rate in the poor metabolizer, we get an overflow. They have a small drain. In an intermediate metabolizer, we have a slightly larger drain. We still get a bathtub that's a little bit more full than we like. This is the way my 10-year-olds fill the bathtub. All right. We can finally have the Goldilocks scenario where everything is just right. So we have the normal size drain and the standard rate at which we've turned on the water, and we get a normal, expected, appropriate level in the bathtub. We can then, as you would expect, have an increased size of the drain, faster clearance, and as expected, we would have a lower blood level, and you get the idea as we move on to the ultra-rapid metabolizer. Now here's where it does get a little bit tricky, and we're going to go into this in detail. But also, like my daughter's bathtub, we sometimes get hair in the drain. So this is the process that we refer to as phenoconversion. In other words, I've given another medication or I've done something else that has changed the size of my drain in the bathtub. And because of that, I now have a difference in the water in the bathtub other than what I would expect based on my pharmacogenetic testing. So I have changed the patient's phenotype by giving another medication. And sometimes we exploit that. Dr. McIntyre just talked about that with dextromethorphan and quinidine, or dextromethorphan and bupropion, where we give a medication that's a 2D6 inhibitor in order to increase the exposure or blood level of the dextromethorphan. All right. Let's briefly move to the other side of the coin. We've been talking about the pharmacokinetic side of the coin. Let's talk about the pharmacodynamic genes, and I'm going to talk about two of them. So the first one that we're going to talk about is that serotonin transporter, where our SSRIs are really working. And what we see is that when we look at studies and we look at meta-analyses, variation here is associated with the trajectory of improvement and the magnitude of improvement. Now, this is where we probably do get into a little bit of trouble, because this isn't necessarily saying that if we have one form of the serotonin transporter, we should switch to a non-SSRI. I don't think we quite have the evidence to do that yet. It simply predicts a different response. The other thing that's a problem here is that this varies a lot across populations, and this varies a lot based on the disorder that we're treating. The other one that we'll talk about is the 5-HT2A receptor. And this is one that has been associated both with the speed and magnitude of response again, but also probably very importantly with SSRI and antidepressant-related side effects. All right, so let's unpack that serotonin transporter that we talked about. We've got two forms. We have a long form and we have a short form. And when we think about the long form, we can think about this as having more of the serotonin transporter. So that presynaptic terminal is going to be slathered with serotonin transporters. Because of that, we will have increased serotonin reuptake. We will also have decreased synaptic serotonin. Now, with our short allele, we're going to have decreased serotonin transporter expression. We're going to have decreased serotonin reuptake, and we'll have increased serotonin at the synapse. And that's something we'll talk about when we try to look at these dose-response relationships like this one. So I love telling people that there's a relationship between blood level and response. And I like it because I'm a little bit oppositional. And many of my residents are also oppositional, and so they'll say, no, there's no relationship between drug level and response. And my question, which I invite you to use, is have you ever increased the dose of a patient's antidepressant? Anybody ever increase the dose of a patient's antidepressant? Guess what? You increase their blood level, right? It makes sense. And likely they got additional benefit. They improved. But my patients point out slides like this. Clearly, there's no relationship between blood level of paroxetine here and response. But we just talked about pharmacodynamics. And so if we look at the pharmacodynamic component and we now break this down, we see that in those people that have the short form of it, we actually get decreased response and more side effects as we increase the dose of the medication. We've already blocked all of those serotonin transporters. We're now getting off-target effects. Whereas in individuals who have the long form, homozygous long for the serotonin transporter promoter, what we see is that there is a relationship between dose or blood level and response. Now, we all talk about these goal doses of antidepressants, right? I want to be at least 40 milligrams of fluoxetine. Probably not good for me. I'm a poor metabolizer. I want to be at 150 milligrams of sertraline. I want to be at least 20 to 30 milligrams of citalopram. Where do these actually come from? Well, they come from receptor occupancy studies like this one. And so what you're seeing here is that as we increase the dose of the medication, we actually block more and more of those serotonin transporters. And where this comes into play is we recognize that we have significant variation in blood levels associated with many of these antidepressants. So our 150 milligrams of sertraline in one patient may not produce the same blood level as in a poor metabolizer of 2C19, and we'll talk about that in terms of how we individualize dosing. What I also just briefly want to introduce is that these variations in pharmacodynamic genes also impact how our medication influences neurocircuitry. And we see that when we look at the relationship between the prefrontal cortex and the amygdala in adolescents with anxiety disorders. So what we see is that we get a difference in terms of the way in which those structures are connected in patients who have at least one long form of the transporter. However, in those that have the short form, we actually have a very different neurophysiological effect in terms of that connectivity. All right, let's move back to what to actually do with our pharmacogenetic testing results. So I tend to use a couple of resources, and these are all non-commercial, generally government-supported or federally funded. So the first one that I often use is CPIC, and this is an organization that is NIH-funded, and it provides recommendations for a number of antidepressants based on the available literature. I also use PharmGKB sometimes. The websites for these are included here. And I like that one because it gives me some guidance in terms of the actual literature that supports the recommendation. It also links a number of sources in terms of information from the FDA, CPIC, and the general medical literature. There is another group, the Dutch Working Group on Pharmacogenetics. I find that a little bit more difficult to access, although it certainly can be helpful. And last, remember, for many of our medications, in fact, at this point, nearly 200 of those medications, we have recommendations from the FDA. All right, let's really get into the details and talk about how you can actually use this information in your practice when you go back to your office on Monday. First one we're going to talk about is escitalopram and citalopram. This is a study now published a couple of years ago, and this is a huge naturalistic study that unfortunately didn't control for many things, and because of that, probably we don't see the same robustness of the signal, if you will. But in any event, what you do see here is that those patients who are slower metabolizers, shown on the left, have higher blood levels compared to those shown on the right. But let's get into the details here. You see this U-shaped curve. This is the patients that discontinued citalopram, escitalopram, either because of side effects or non-response. And what you see is the extreme phenotypes, so the ultra-rapid metabolizers or the poor metabolizers, both were more likely to discontinue the medication. Now, as expected, the poor metabolizers were more likely to discontinue because of side effects. The ultra-rapid metabolizers were more likely to discontinue because of non-response. As expected, you see the blood level, again, much higher in the poor metabolizers, and then decreasing, as you would expect, as metabolism increases. Now, when we look at these pharmacogenetic testing reports, we can't just look at them in isolation. We already talked about the fact that we need to consider concomitant medications, but we also need to consider things like aging. And so what you see again from this very large study published in the American Journal is that after about age 65, we see blood levels increase. And what that probably relates to is actually a decrease in the activity of 2C19. So after about age 65, this is really important, we start to see a decrease in the activity of 2C19. Now, these are pediatric data, so children and adolescents up to age 17, but I think it's still really important. And in this study, we actually controlled for a number of the factors that weren't controlled for in the earlier study. And what you see is a clearer relationship between how the patients metabolize or clear the medication and their phenotype. So poor metabolizers shown on the left with low clearance versus the ultra-rapid metabolizers shown on the right. So what does this actually mean? Well, what you see here is oftentimes how I titrate escitalopram. I start at 5 milligrams, particularly in a pediatric patient, then 10 milligrams, then 15 milligrams, and 20. What you're looking at is everyone essentially getting the same size blue genes. So that poor metabolizer, shown in blue, has substantially higher blood levels at any given dose compared to the normal metabolizer shown in green. Whereas that ultra-rapid metabolizer shown in orange has much lower exposure, blood levels over time, compared to the normal metabolizer. Now, I already mentioned a lot of times that I am a visual learner and I love these NEI graphics. So this is one that I have pulled from our recent case book that shows the relative contribution of each of these enzymes, and it shows the ones that have been implicated in metabolism of escitalopram. So we know that 2C19 and to a lesser extent 2D6 are factors that influence this. But this is not a slide about pharmacogenetics. Oftentimes we think just about the relative contribution of 2C19. But you already told me that many of your patients, like mine, also smoke cannabis. And so what you're seeing here is now two patients, one not using cannabis and one using cannabis. And what you see is that in that patient treated with escitalopram who's using cannabis, number one, it takes longer to get to steady state. Number two, they are going to have higher blood levels than the comparable patient that's the same metabolizer type not using cannabis. We also see relationships between two. Now, I already mentioned a lot of times that I am a visual learner and I love these NEI graphics. So this is one that I have pulled from our recent case book that shows the relative contribution of each of these enzymes, and it shows the ones that have been implicated in metabolism of escitalopram. So we know that 2C19 and to a lesser extent 2D6 are factors that influence this. But this is not a slide about pharmacogenetics. Oftentimes we think just about the relative contribution of 2C19. But you already told me that many of your patients, like mine, also smoke cannabis. And so what you're seeing here is now two patients, one not using cannabis and one using cannabis. And what you see is that in that patient treated with escitalopram who's using cannabis, number one, it takes longer to get to steady state. Number two, they are going to have higher blood levels than the comparable patient that's the same metabolizer type not using cannabis. We also see relationships between 2C19 and weight gain for escitalopram. And again, as my good friend Jonathan Meyer likes to say, this is an example of how it may not change what we're doing, but we at least turn on the headlights so that we have a sense of perhaps who may be at greater risk of developing weight gain associated with an SSRI. And so again, what you see here is that those poor metabolizers, they gain weight early, and they gain a lot of weight. Versus those ultra-rapid metabolizers, if they do gain weight, it's relatively slow. And this is incidentally corrected for age, sex, race, and dose of the medication. Let's move on to one more antidepressant, sertraline. Another slide for the visual learners like me. So sertraline is primarily metabolized via 2C19 and 2B6. And so what you're seeing here, again, just like we looked at with escitalopram, is if I use the standard dosing, the Strawn dosing that I use, what happens to the blood levels over time? Well, you see one of those curves looks very much not like the others, and that is the blue curve, the poor metabolizer. So how can I actually use this in my practice? Well, let's say we're going back to that goal dose of 150 milligrams. That's based on the normal metabolizer. So if I'm treating a poor metabolizer and I need to get to the same blood level, I only need 50 milligrams of sertraline in order to get there. Whereas if I have the ultra-rapid metabolizer, I need a little north of 200 milligrams to get there. But sertraline is a little unique because it's not just 2C19, it's also 2B as in boy 6. And this is a table that's modified from our CPIC guidelines, and it's this is really tough. It's kind of like pharmacogenetic bingo, right? Like, well, I'm ultra rapid here and a poor metabolizer here, so does that, and the patient smoking cannabis, so, right? This is where it gets really complicated. I don't have this memorized, I would look it up. All right, let's talk about fluoxetine. We have to talk about two aspects of fluoxetine. This has been one that, as we all know, competitively inhibits 2D6. The issue here is that we don't have pharmacogenetic recommendations because our metabolite is also active, and that makes understanding the relationship between blood levels and response very, very difficult. But this does have implications in terms of some of our augmentation strategies, and we're going to talk about that as well. The last SSRI that we're going to talk about is paroxetine. I don't use it much, but it is interesting in that it emphasizes a couple of points. So paroxetine is a potent inhibitor of 2D6, and we're going to talk about that more in the next slide. So we know when we look at blood levels over time, yes, we see a dose relationship. Higher blood levels in general associated with higher doses, but we have a number of outliers. And we do think that some of this relates to variation in 2D6. But here's where paroxetine gets really complicated. Has anybody ever managed paroxetine withdrawal? Yeah. Anybody like managing paroxetine withdrawal? It is like my least favorite thing to do, other than venlafaxine withdrawal. Why is paroxetine withdrawal so bad? Well, what happens is paroxetine binds to 2D6, and it does so irreversibly. So the only way that we can actually restore that activity of 2D6 is by making more 2D6. So what happens is we all talk about the half-life of paroxetine being somewhere in the order of 8 hours. What happens as we increase the dose of paroxetine, our clearance actually decreases because we completely inhibited and inactivated that 2D6. Well, that's fine, that's great, but what happens when we reverse this phenomenon, right? when we experience paroxetine withdrawal. Our clearance speeds up and up and up and up and up, accentuating the withdrawal symptoms that we see because of this phenomenon that we call mechanism-based inhibition. All right. I alluded to the fact that we don't have much in terms of recommendations for paroxetine. Venlafaxine, my other least favorite antidepressant. It's a box of chocolates. You just don't know what you're going to get. So venlafaxine is metabolized to desvenlafaxine. Venlafaxine is primarily a serotonin reuptake inhibitor, whereas desvenlafaxine is primarily a norepinephrine reuptake inhibitor. And so what we see here is that the relative contribution of these enzymes, about 80% of this conversion is going to be dependent on 2D6. And if you weren't convinced that the data you're getting here in Las Vegas are fresh, these are data that were just released 21 days ago. So very fresh data in terms of those relative contributions. So we know that there are differences between the poor metabolizers and the normal metabolizers, but there's more to the story. So when we're looking at 2D6 and we're looking at the slower metabolizers here, they're going to have more of the venlafaxine concentration relative to the desvenlafaxine concentration. As we speed up 2D6, we're going to have more desvenlafaxine relative to venlafaxine. That's important because we know that we have NRI, norepinephrine reuptake inhibitor-associated side effects like hyperhidrosis and various cardiac side effects in terms of increases in heart rate and blood pressure relative to the SRI effects, sexual dysfunction, weight gain, etc. All right, risperidone in 2D6. Very, very similar to venlafaxine in that it's also metabolized via 2D6 and is also an inhibitor of 2D6. So what we see here is the expected decrease in blood levels, right, as we move to the poor metabolizers. But it's complicated with risperidone. And the reason is because since the brain to blood distribution ratio of risperidone is twice that of the metabolite, the paliperidone or 9-hydroxyrisperidone, the difference in blood levels that we see in the plasma doesn't necessarily reflect what's going on in the brain. The other thing that we know is that as we have more of the metabolite, the paliperidone or 9-hydroxyrisperidone, that's going to give us more hyperprolactinemia relative to the risperidone. All right, aripiprazole in 2D6. We're going to talk about that in another few slides. I want to spend a moment or two talking about 3A4. And this is something that's often included in many of our pharmacogenetic testing reports, and you saw from that early slide that 3A4 is responsible for metabolizing many of our atypical antipsychotics, several of our antidepressants, and really myriad other psychotropic medications. Now, 3A4 and 3A5 are actually the predominant enzymes in the liver. 3A4, interestingly, probably dominates in whites, whereas 3A5 dominates in blacks of sub-Saharan ancestry. But really, there's tremendous overlap between the 3A4, 3A5 family. We know that they may metabolize in some way, shape, or form up to 50% of medications. So here are the take-home points, because this is really not a pharmacogenetic story. We certainly do know that there are some forms that do influence metabolism, but by and large, most of the variation in 3A4 and 3A5 comes from environmental factors. It comes from concomitant medications, things we're eating, things we're smoking, etc. We also know that it's influenced by sex, so women tend to have a little bit higher activity in 3A4. And then we certainly know about other interactions, which we're going to talk about. So I mentioned that hair in the bathtub, that process of phenoconversion. We certainly leverage this in our practices when we use these strong 2D6 inhibitors or even the moderate 2D6 inhibitors. We also have 3A4 inducers that we just saw one slide ago. But we're going to talk about a specific example here. We know that fluoxetine and aripiprazole are both metabolized via 2D6, and we know that variation in 2D6, as you can see, is associated with variation in blood levels for aripiprazole. But one of my common strategies in terms of augmenting for patients with SSRI-resistant depression is to add aripiprazole. Do others have a similar strategy? We just heard Dr. McIntyre talk about that. I think that's pretty common. The issue is I have a lot of patients that are treated with fluoxetine. And so here's where phenoconversion becomes really important. Because if that patient was a normal metabolizer for 2D6, I've potentially converted them to a poor metabolizer. Or if they were an intermediate metabolizer, I've converted them to a poor metabolizer. So when I go to augment with my aripiprazole, I can't use my normal starting dose of aripiprazole. If I'm following the labeling, I have to reduce that dose by about 50%. Again, not the same size genes for every patient. So here are the recommendations, which you certainly have in your handouts for 2D6. We have consideration of an alternative recommended for paroxetine and vortioxetine. No significant interactions other than a lower starting dose for paroxetine for intermediate metabolizers, and then you see the recommendations there for the poor metabolizers. For 2C19, we've reviewed most of the data with regard to citalopram and escitalopram and sertraline, and you see those recommendations there as well. For pharmacodynamic genes, it's pretty easy. No recommendations. No recommendations. Moving on, how do we actually use this and how do we talk about it? So this is a slide that we put together for, interestingly, a pediatric journal, but I think it very much applies to what we do with adults as well. So what you see there in the first gray box is our clinical approach. And really, we can think about pharmacogenetics like absolutely any other laboratory test that we have. Whether it's an MRI, an EEG, a urinalysis with a culture and sensitivity, etc. It doesn't replace our clinical decision making. So what I would advocate is that we are still approaching the patient as we would clinically. We're considering comorbidity, we're considering target symptoms. Do I have prominent anhedonia, as Dr. McIntyre just talked about? Do I have prominent insomnia? Is that something that I may want to target in terms of a specific pharmacotherapy? Is there something else in terms of concomitant medication that influences this? And most importantly, what does the evidence actually say for that particular medication? Having considered all of that, I probably have something in mind. And so now what I would do is, if there are recommendations available, that's a situation in which I would consider testing. And then based on the recommendations, again, for the pharmacokinetic genes, I would consider a difference in terms of dosing or titration, or perhaps choosing an alternative antidepressant if it were appropriate. So how do we communicate this with patients? And this is really where I get stuck in the office. So I think we need to be very clear that this is not something that picks what medication will work. And I think that myth has been propagated for some reason, probably with regard to just the need for some therapeutic hope, that there's something that increases certainty in our prescribing choices or in for the patient, what medication my clinician chooses. So thinking about it as this is something that helps, it is a decision support tool. We can talk about the relationship on the PK side, pharmacokinetic side, in terms of blood level and side effects, or blood levels and dosing. So in general, what pharmacogenetic testing may do, it can guide dosing as we talked about. It may explain some concentration-related side effects. We have a lot of evidence for this on the pediatric side, somewhat on the adult side as well. It may identify some patients at risk for higher toxicity. I, for example, would probably experience toxicity if I were treated with fluoxetine or amitriptyline. What it doesn't do, it does not replace who we are or what we do. It does not supplant our years of clinical training. It does not pick a medication. It does not guarantee that a medication will work or will not work. And it by no means eliminates the need to monitor our patients. So we're wrapping up. The last two slides here. How do we've talked about how we appraise genetic and environmental factors. By environmental factors, I mean concomitant medications. I mean things that the patient may be smoking. I mean adherence. I mean other factors. We've talked about the influence of 2C19 and 2B6 as well as 2D6 with regard to specific medications. We've talked about faster 2D6 metabolism as that relates to differences with venlafaxine and also with risperidone. We've talked about the pharmacodynamic genes, although really I think we're not quite ready in terms of the evidence that we have. And we've also talked a bit about how to implement pharmacogenetic testing. Again, what it is and what it is not. What it does and what it does not do. We've talked about the way in which we could use genotype in order to help individualize dosing. And we've talked about some of those independent resources and finally talked really about how we should scaffold this communication with our patients and their families.